So we are going to go ahead and get started. Good afternoon, everyone. Thank you so much for joining us here today. To join us for the webinar is Lung Cancer Screening Right for Me. Today, we're going to be discussing lung cancer from screening to diagnosis and treatment. And we are lucky to have the top experts on lung cancer from New York Presbyterian Brooklyn Methodist to walk us through all aspects of the journey. My name is Elizabeth Aloni, and I'm with Schneps Media. Schneps Media is the largest local media company in the New York metro area. We publish over 70 newspapers, magazines, websites, webinars, podcasts, and events throughout Queens, Manhattan, Brooklyn, the Bronx, Westchester, Long Island, the East End, and Philadelphia. And I'm very much looking forward to this discussion. So let's get started by introducing our panelists. Please first welcome Sabran Harrison, MD, Chief of Thoracic Surgery. Dr. Harrison has a special interest in the area of thoracic oncology, specifically lung cancer and esophageal cancer, as well as benign diseases of the esophagus. His research has been published in a number of distinguished medical journals. Dr. Harrison is a member of the Society of Thoracic Surgeons and of the Association of Academic Surgeons. He is board certified by both the American Board of Surgery and the American Board of Thoracic Surgery. Welcome, Dr. Harrison. Next, I'd like to welcome Anthony Salam, MD. He is a program director, Pulmonary Critical Care Medicine Fellowship Program. Dr. Sala is extremely active in the field of pulmonary and critical care medicine, both clinically and academically. He's a member of many medical organizations, including the American College of Chest Physicians, the American Thoracic Society, and the American College of Physicians. Dr. Sala has lectured extensively, both nationally and internationally, a variety of pulmonary topics, including lung cancer, interstitial lung disease, and you'll correct me on that, and pulmonary effects of COVID. He's won numerous teaching awards and has been recognized as a top doctor in many publications. And finally, welcome, Dr. Sala. We're happy to have you.
Thank you.
And finally, let me please welcome Jennifer Liu, and nurse practitioner. Jennifer Liu is a family nurse practitioner who specializes in pulmonary medicine at New York Presbyterian Brooklyn Methodist Hospital. She completed her Bachelor of Science in Nursing and began her work journey with New York Presbyterian Brooklyn Methodist in 2011. She went on to pursue her Master of Science in Nursing at Long Island University and transitioned to her role as lung cancer screening coordinator, pulmonary nurse practitioner, and lung transplant coordinator. As a lung cancer screening coordinator, she meets with qualifying lung cancer screening candidates to discuss risks and benefits of participation and offers counseling for smoking cessation. Welcome, Jennifer.
Great, thank you.
Quite an amazing group. We are lucky to have them here with us today. So let's get started. Jennifer, screening guidelines always seem to change, and it can be hard for a patient to keep track. What are the current cancer screening guidelines?
Right, so in March of this year, actually, the United States Preventative Services Task Force, they had just recently changed their recommendation, reducing the age requirement. So it went down from 55 to 80, now currently to 50 to 80 years old. In addition to that, they also reduced the pack year history from 30 to 20 pack years of smoking. So that definitely broadened the range of screening. With that said, because this is a grade B recommendation, which means that there is a moderate certainty that the net benefit is moderate to substantial, some of the insurances have not yet adapted to these new changes, but we're starting to see more of the insurances coming around and covering most of these.
That's actually very good news. Whenever there's an opportunity for more people to get screened, I think that's probably a better thing for sure. Mm-hmm. When you say package, can you explain what you mean by that?
Sure. So the pack year would be calculated by the number of years that they smoked times the amount of cigarette packs that they smoke. So for example, if someone smoked for 30 years with 1 pack a day, that would be an equivalent to 30 pack year history.
Terrific. Thank you for clarifying that. I appreciate that. Dr. Sala and Dr. Harrison, are there symptoms of lung cancer?
So, thank you, Elizabeth. The symptoms from lung cancer, and one of the reasons it remains a real plague amongst Americans and really around the world is that the symptoms are so nonspecific. Some people may get more short of breath. They could be short of breath from their emphysema, from bronchitis, so it's nonspecific. Some people may have coughing up blood, but a lot of things can make you cough up blood. So the symptoms of lung cancer are so nonspecific, which is why many of these people, about 2/3 of them actually, present with advanced disease. And that is why we're so excited about screening, because the best way to cure lung cancer is to take it out early on, before it's spread, before it's advanced. And that's where screening has played a huge role. You know, many other cancers have screening, right? Prostate, where everybody gets a PSA, everybody gets a colonoscopy, many women get mammograms, right? So many other cancers have extensive screening, yet lung cancer, which I want to say, if you add breast, prostate, colon, and pancreas cancer, the four next after lung, if you add the deaths per year that they cause, lung cancer exceeds those.
Wow.
Lung cancer exceeds, 1 year, the deaths from lung cancer exceed colon, prostate, breast, and pancreas combined. So for such a high burden disease, we for many years had no screening. This is why we're so excited, and we really want to screen as many people as we can, because if we find an early lung cancer, that's when we can get them to Dr. Harrison and have a state-of-the-art, standard of care surgical approach that can give them much better cure rates.
That's really incredible information. I had no idea that lung cancer was so prevalent, and that there were so many deaths, so many more than the other cancers that people know about.
Yes.
Wow. Dr. Harrison, you know, why, well, obviously this is why screening is so very important, but should everyone get screened? You know, I mean, hearing that, I'm like, when can I get screened? Tell us, you know, are there priorities? You know, who should be thinking about this?
Yeah, definitely. And this is always a discussion that is difficult, because just like you were saying, you know, once people hear sort of the high rates of lung cancer and how deadly lung cancer is, then we have many people who are not even considered high risk for lung cancer wondering if it's appropriate for them to be screened. And as right now, the best data that we have, we know that the people who should be screened for lung cancer are those who fall into those high risk categories. Just as Jennifer was talking about there, these heavy smokers of a certain age. You know, not to go off into it too much, but to the point of, well, why not screen everybody? And that's because, you know, obviously there are some downsides to screening. We may find something that we don't know exactly what it is, and it may not be anything at all, and it, you know, contributes to a person getting, you know, further screens or further scans and whatnot than may be appropriate. And so that's why we really want to focus mainly on those high risk patients with the heavy smoking history that Jennifer was talking about. Those are really the best patients who should be getting the low dose CT scanning for screening.
What about those who like live with people who are heavy smokers? Are those people considered, you know, people who are heavily around secondhand smoke? Do they fall into a similar category?
So secondhand smoke, the jury is still kind of out on it. We know it's nowhere near as bad as actually smoking. There are some scant studies that suggest the risk is slightly increased, but nowhere near smoking. So I think pending more studies and more data, we could say that secondhand smoke, while not wonderful, is nowhere near as bad as the primary smoker.
Got it. And what about hereditary? Because I know so many cancers, they speak about family history. What about with lung cancer?
Definitely, it's hereditary. There are strong genetics involved in lung cancer. We have familial cases. And what ends up happening is that many of these patients have that familial gene, and the smoking perpetuates it and exacerbates it and brings it out. So again, smoking anything is bad, but particularly lung cancer, it's the worst. And by the way, smoking has many other bad things that it causes: heart disease, bladder cancer, esophageal cancer, emphysema. A plethora of bad clinical outcomes come from smoking, but certainly we know for lung cancer, it's the worst. And I'm going to see, I just saw a question about, is there a link between lung cancer and marijuana smoking? So the answer to that is we're not sure yet. Now, we do know marijuana causes lung disease. It can cause cysts in the lung. It can cause a pneumothorax or a collapsed lung. So marijuana is not any good for the lung either. We don't have the strong link with marijuana and cancer as we do with cigarette smoking and cancer, but it may cause other entities which can scar the lung. And once the lung is scarred, it is at risk for cancer. So as I tell my kids and my patients and many people, the only thing you should be inhaling is air. Nothing else should be inhaled in your lungs.
I think that's a really good point. I mean, I think, something that we see in the news, and I know I have children, I mean, they're a little young, but still 10 and 12, you start thinking about this vaping. Vaping has become, and not just with children, it's rampant with adults. Is vaping just as bad?
So there are lots of vaping-related lung issues. And as a matter of fact, before COVID, right before COVID came on, the hottest topic in lung disease was vaping. There were a bunch of young kids who were getting very sick from vaping. And then, of course, COVID came out and the whole world changed. And we know that vaping, while it's only been around maybe 10, 15 years, can cause severe lung damage. And down the line, it may indeed be implicated in lung cancer, but we know that it's not good.
Right, right. And would you say like vaping and marijuana usage, I mean, would part of the reason why there's not a strong link to lung cancer is because it really hasn't been researched as long or as fully?
Yes, exactly right. Exactly right, Elizabeth. So it hasn't been researched as much. We don't have the data. And quite honestly, they haven't been around as long, right? Cigarettes have been around for over 100 years. Vaping really only 10 to 15 years. And marijuana, while it's been around longer, of course, not everybody says they smoke marijuana. So we don't have that kind of robust literature that we have on lung cancer with cigarette smoke.
But it's certainly best to abstain and to make sure that you keep your lungs healthy, because just because there isn't proven lung cancer,
doesn't mean it can't happen.
I'm telling them for sure. So it's really to keep yourself healthy is important, not to only inhale
air.
Let's keep that clear. Thank you so much for that. So let's get into, Jennifer, Dr. Sala, can you talk to us a little bit what's involved in screening?
Sure. So screening involves first having a shared decision-making visit, meaning that, I discuss the risk and the benefits of screening, like Dr. Harrison had mentioned. Just because, with radiation, that always is a concern. But the benefit, obviously, with the screening is that if we can detect it early, then we can address, lung cancer early on. So patients are going to meet with me first, and then they're scheduled to come in for a low-dose CT afterwards, which the scan will take about 2 minutes to actually be done, which is pretty quick. And And then they're usually contacted about 24 to 48 hours after the results are in. And then I'll call them and discuss the recommendations and the results.
What is the scan like? Is it like an X-ray? Is it like an MRI? What is?
Exactly. Similar to an X-ray. And radiation-wise, it's the equivalent of having, they said like 120 hours of ambient radiation in your background in your home.
Oh, okay. Okay, well, we all have that, so shouldn't be afraid to get scanned if it's important for you to get scanned. Dr. Sala, can you tell us a little bit about the Mazzilli program?
Sure. So we in 2012 partnered with the Fred Mazzilli Foundation. I'll give you a little background. Fred Mazzilli was a patient of ours here at New York Presbyterian Brooklyn Methodist, who was really a Renaissance man, a lovely guy, beloved in the community, who was a smoker and unfortunately died of lung cancer. His brother was the famous baseball player Lee Mazzilli, who actually played for both the Yankees and the Mets. And he was a manager, a very well-known baseball guy. And when Fred passed, his family, both Lee's wife, Danny, Fred and Lee's sister, Joanne, and her husband, Mike, and the whole family wanted sort of not to let his legacy just be that he passed from lung cancer. They wanted to honor his memory with something that could help people who are alive. And we actually have the first and still the biggest lung cancer screening program in Brooklyn. And those funds are funded by the Mazzilli Foundation, who prior to COVID would have a big fundraiser and have really given a tremendous amount to the hospital in terms of dollars. And those dollars go towards those screening lung CAT scans. As Jennifer mentioned, a screen mainly consists of a low-dose CAT scan. And certainly early on when we started our program, nobody was paying for those scans, no insurance. So rather than having a patient saddled with that bill, which could be significant, the Mazzilli Foundation funded all of those scans. So we have a wonderful relationship with them, and we continue to grow. You know, COVID changed things a little bit. And again, this is the type of collaboration that we really love, in that we have the pulmonary doctors, we have great thoracic surgeons like Dr. Harrison, we have the oncologists, we have radiation oncologists. Unfortunately, my colleague, Dr. Keshava, who was supposed to be on this webinar, had an emergency. She's actually taking care of very sick patients. She does an incredible job with procedures. So we feel here at NYP BMH, we have the entire gamut of team. We have everyone who's needed to put patients in the right position, both to be screened and, if indeed something is found, to offer them standard of care, state-of-the-art therapy.
And that really takes me to my next question. I would love for you and Dr. Harrison to share with us, you know, if something is found, what are the next steps?
Yeah, so obviously if, you know, a patient is screened and they have a concerning lesion that is seen, the very first thing that we want to do is we want to diagnose it, which means that we typically, if it falls within certain parameters, we would likely recommend a biopsy, which is taking a small piece of the nodule so that we can diagnose whether this is cancer or not. There are many, many ways of doing that, and relatively non-invasive, depending on kind of where the lesion is located. Often enough, our colleagues like Dr. Sala can do a quick outpatient procedure to biopsy that so that we diagnose what the nodule is. Sometimes if they're in other positions, they need a needle biopsy, like perhaps a lot of women are familiar with in terms of breast biopsies and whatnot. It's a similar sort of thing. So really depending on the characteristics of the nodule that we see on screening, typically the next step, if it is something concerning, would be a biopsy.
Okay, thank you for that. So you'd biopsy it, and then let's say you find out it is cancer. Do you at this point know how extreme, like, what level it is?
Yeah, so wonderful question. And we always think cancer in terms of diagnosis and then staging. So once we diagnose it and we know that it is cancer, to your point, the next most important thing is that we want to stage it. Staging is just another term for us to know how far along the cancer is. The earliest of the early is when the cancer is in the lung and is not moved anywhere else. And that's absolutely where we want to be when we have a lung cancer. And then obviously, as the cancer progresses, it can move to other places. So once we have a diagnosis, then we stage. Staging can come in a few different forms. Probably a lot of the viewers are familiar with something called a PET scan, a PET scan, or perhaps colloquially known as a whole body scan. That's a specialized imaging similar to a CAT scan that lets us know if there's other lesions that perhaps the cancer has moved somewhere. And then just depending on what we see from that, we may need to perform another biopsy or go straight towards definitive treatments of the cancer that we have.
Okay, so we do the biopsy, we learn that it's cancer, we learn that it's a certain stage, then where would a patient go?
Yeah, I mean, it really depends on what the stage is. And the whole purpose of lung cancer is we want to find those patients with stage 1 lung cancer, meaning a cancer that is in the lung and has not moved anywhere else. And that is really in the area that we have some good treatments for. Gold standard treatment for stage 1 lung cancer has been considered, sorry, I'm right beside the ER, so you're going to hear an ambulance or something every now and then. But so gold standard treatment has been considered surgical resection, so a lung surgery, and I'm happy to talk about that if people have questions. That's not nearly as, I mean, it's a serious surgery without question, but we have newer techniques where we can do that minimally invasive through small incisions and special instruments to really try to get those patients through their cancer surgery and back to their lives and doing everything that they were before surgery, which is always the goal. There are other treatments as well. There's some newer treatments that our radiation colleagues can offer for appropriate patients and whatnot. So we just have so many more options for patients the earlier that we stage the cancer.
Fantastic. Thank you for that. And all of this is available right in your cancer center.
Yeah, I mean, I think, and Dr. Salo was mentioning this earlier, and I can't say it enough. I mean, we have all of the parts here, and it's just absolutely wonderful how much of a team atmosphere that is here, you know, working with folks like Dr. Sala and Jennifer and our other colleagues who aren't on the call. I mean, there's absolutely no weak link here at Brooklyn Methodist, and it's just a pleasure to work here. And I think that once our patients are here, they really, really appreciate that. It's kind of a team and a family and a community atmosphere that they're just not going to find anywhere else. And it's a lot of those intangibles that people don't often, you know, think about when they have these familiar faces that they've known for so long, rounding on them in the hospital, seeing them every day, knowing that they're very invested in their care. I just think it's a special place to get cancer treatment here.
Yeah, absolutely. It sounds like it, to be able to work with a team of doctors, nurse practitioners, and all those other individuals who are part of one's care, and knowing that everyone's communicating with one another to make sure that the right care is given to the patient. Dr. Sala, do you want to add anything more in terms of steps once someone finds out that you know, they do have cancer?
Well, it's hard to add anything to Dr. Harrison's eloquent description. I really would just follow up by saying it really depends on if it's early stage, we look for surgical resection. If it's later stage, we have many other therapies. Now, one thing I will add is in the past, if people had advanced stage cancer, many times we didn't have a whole lot for them. That has changed now. Over the past 5 years or so, a lot of lung cancer therapy, even in advanced lung cancer, is personalized. And by that, I mean, instead of looking at the tissue, just saying it's cancer or not, we now look at the tissue much more in depth, and we look at what's called mutations and markers. And many of these people who in the past would have not had a whole lot other than maybe some chemotherapy, now we can offer them what's called targeted therapy, which A, is very effective, and B, is much less toxic to the patients, much better tolerated. So again, these are advances that are remarkable in terms of how many patients' lives are positively impacted. And we also here at our hospital have every 2 weeks a multidisciplinary tumor board where a lot of cases will be presented, and we'll have radiologists, pathologists, thoracic surgery, pulmonary, many times other specialists that'll talk about the case and come up with the best way to manage. That could be someone who has full-blown cancer, or that can be someone that Jennifer alerted us that a screening CAT scan from the Mazzilli Foundation may have been suspicious, and we'll talk about that. And that's the type of approach we try to give every patient here.
And that's extraordinary when you think about it, that you have all of these specialists, all of these individuals with all of this knowledge coming together and looking at your tumor and understanding specifically for that patient what is the best next steps. And it's also very encouraging to hear that there are steps that can be taken that are less toxic to the body. So thank you for that. I also wanted to know, because we talk so much about smoking, are there other risks beyond smoking that can lead to lung cancer?
That's a great question. And yes, there are. The biggest risk is smoking, but there are others. Asbestos can cause lung cancer. Now, asbestos is really bad. Not only can it cause lung cancer, it can cause a very bad disease called mesothelioma, which is a pleural cancer or a cancer of the lining of the lung that is a very aggressive type of cancer. Other exposures can cause lung cancer. Benzene, which is a chemical pretty widely available, has contributed to lung cancer. There also is, and there was some data about radon causing lung cancer. So while smoking is indeed far and away the overwhelming main risk for lung cancer, there are indeed other entities that cause lung cancer. And as I mentioned earlier, scarring can cause lung cancer. So let's say someone didn't smoke but had bad scarring of the lungs, some fibrosis, that can be a nidus for eventual cancer. So while smoking is certainly the main player, there are other bit players to the development of lung cancer as well.
How would that happen? I mean, is that something like, for example, like with COVID and the damage that it does to the lungs? I mean, what would create that situation where...
So that's a great question and something we're intensely looking into now. So there are many fibrotic lung diseases. Sort of the one that is most prevalent is idiopathic pulmonary fibrosis. And we know people who get that usually are smokers, but not exclusively. So anything where the lung is scarred, such as fibrosis, can cause lung cancer from scarring. Now, what about COVID? We are finding, and I just gave a lecture on this, and this is becoming a very critical topic as we move forward, that the severe cases of COVID can cause scarring. Now, remember, COVID is just celebrating its 2-year anniversary in China, and it's not even 2 years clinically available here in the States. So it is too early to say whether that scarring causes cancer, but I think that's going to be a phenomenally important question as we move forward, is that does the scarring that some COVID patients get, fortunately not all, usually the severe COVIDs who are on a ventilator, etc., do they go on to develop lung cancer? And that's data that we all are very anxiously awaiting the results of.
Yeah, I'm sure. I'm sure. Thank you so much for that. So it's really important to kind of know your risk factors and make sure that you get screened.
Yes.
Have those risk factors, try and catch it early if it is an issue, and certainly go to Brooklyn Methodist Hospital because of all of these special coordinated efforts that you have to make sure that the best care is given to each patient. Jennifer, I have a question for you. How do you get your loved one to get screened? We all have that loved one who, although should get screened, is kind of leery about it. What would you recommend that we do for our loved ones to make sure that they get screened?
Great question. So definitely anyone who believes that they fit the criteria, who have had a smoking history, greater than 30 years, you can definitely contact me. My phone number is the 718-780-LUNG, 5864. Feel free to have them call me. They can ask me any questions. It's definitely a great program to get the word out.
So encourage them, let them know really how important, I think what we learned here is, what a difference catching it early can make, that if you are with a high risk factor, that you certainly should. And as you said, I think with you, they now approved it as young as 50, correct?
Correct, right.
So, really maybe if you have a person in your family who's a little resistant, start talking to them at 49, get the head, as you also work on getting them to quit smoking. But I am going to share with you the number that Jennifer just gave to you in the chat, so that you could learn more or make an appointment for a lung cancer screening. I'm sharing that phone number, 718-780-5864. And I'm also sharing the link that you can click on. And I will also tomorrow, you'll all get a thank you email from me, and it'll include that information there, as well as a link to where you can find the recording of this. So you could also show this to a loved one who is a little bit resistant, and perhaps that will help getting them to get screened as well. Thank you so much for this information. I'd love to jump. We have some great questions from our attendees that I would love to get to. So let me jump over there. John says he's 74 years old. And for 25 years, he smoked 2 packs a day, but hasn't smoked for 25 years, and currently gets a yearly lung CT. So good for you, John. Should he continue? Does damage risk ever decrease? What are your suggestions here?
So, John, thank you. That's a great question. First of all, if indeed that is you, congratulations on not smoking for 25 years. Clearly one of the best decisions you've ever made. Now, the fact that you stopped, or this patient stopped 25 years ago, takes you out of screening. Right now, we have screening 50 to 80 years old, right? So age-wise, you would fall in. Pack years you fall in, that's 50 pack years, 25 years, 2 packs a day. I don't know where the heck you find the time to smoke 2 packs a day, but a lot of people, I guess, can do that. But usually if you've stopped more than 15 years ago, you don't get screened anymore. Now, the damage risk does decrease, but it doesn't fall to 0. So that's why the best smoking is no smoking. Never put yourself at any risk. But the fact that 25 years has gone is a good sign. It's good that that the patient hasn't smoked in 25 years, and the risk definitely decreases, but does not approach 0. Now, having said that, while you may not be a candidate for screening, if you were to develop any symptoms such as coughing up blood, such as worsening shortness of breath, I would have a low tolerance to do an X-ray and, if need be, another CAT scan. So hopefully that answers your question.
So if John is getting these yearly lung CT and they are being covered by insurance, would you recommend that he continue to do so? Because you mentioned about the scarring and
right. So by the guidelines, he does not require a yearly CAT scan anymore. And again, that's where I would use good clinical sense. If he had symptoms that suggested something else was going on, he could have a scan, but it wouldn't be part of that yearly 3-year scan that we do for screening.
Well, congratulations, John. You made a really good choice 25 years ago. So
yes.
Work. Jill wanted to know, how do you know 100% if cancer has spread if you don't see it on scans? Can you check cancer in the bloodstream? She wants to know. Would you always see cancer on a screen?
So, I would say in terms of cancer spread, so I think that the question is, if we know that there's cancer and we do all of our other tests, how can we be certain that it hasn't moved anywhere? And that's a very good question. That brings up something, not to be too technical, but there's something called clinical staging, which means the best idea that we have how far the cancer has moved from everything that we do before we start treatment. So our CAT scans, our PET scans, our biopsies, what's the best clinical stage? Then we have something called pathological stage, which is the stage once we have the surgery, we take everything out and our pathologists look at it and they tell us exactly how large the cancer is and if it has moved anywhere to the lymph nodes. But actually our clinical staging is quite good. When you look at sort of modern studies that have looked at both CAT scan and PET scan and biopsies, the ability of us to accurately clinically stage someone approaches 90-91%. So it's actually quite good. It's an interesting question that she brought up, because it's one that we talk about a lot in our tumor boards and whatnot. How confident are we in the scans that we have? But actually in the modern era, our CAT scans and our PET scans are quite good. And so we've got good clinical staging. And so for the most part, if someone has a very, very early stage cancer based upon their scans and their PET scans, we can be accurate with a 90-91% certainty that that's what they'll have on final pathological staging after it comes out.
Wow, that's really a blessing to be able to have such tools. Thank you for that. Lisa wanted to know, what is the percentage of lung collapse in biopsy of a nodule? And is that a big risk factor?
Yeah, I mean, I can answer that one. So when people talk about collapsed lung, what we're implying there is that for some reason, whether something that we've done or some underlying problem with the patient's lung, air has escaped out of the lung into the chest, and that air that is in the chest puts some pressure on the lung. That could be something as very mild as you wouldn't even know it unless you had a CAT scan, to something that's a little bit more serious that we would have to intervene upon, like put a little drain in the patient to release that air. Historically, when people have looked at the risks of a collapsed lung after a lung biopsy, it's somewhere on the order of 10 to 20%. And that sounds high, but remember, that's every single person who comes in, and there's a lot of issues that patients can have that increase their risks, such as if they have severe COPD emphysema, that increases their risk. If the tumor is located very centrally in the lung, so this needle has to go further through the lung tissue, that can increase the risks. And we do certain things at the time of the biopsy to make sure that that patient is completely stable, such as we watch them. We watch them and we get x-rays, and our radiologists who do the biopsies, they stay with the patients and make sure that they don't have a problem before they leave after the biopsy. The chances that a patient gets a biopsy and has to have something done to them, like say the drain that I talked about, or have to come into the hospital, is actually quite low. It's about 5% or less. So it's a very, very safe procedure.
That's good to know. We certainly don't want that to keep someone from going in
exactly
biopsy, because if they have cancer, that is much more of a risk. right?
Yeah, and just to also bring it up again, I mean, this Dr. Saylor was talking about our multidisciplinary tumor board. These are all issues, and these are wonderful questions. These are absolutely outstanding questions because these are the exact same things we all talk about in that tumor board. So how good is our clinical staging, and what's the risk of a biopsy with this patient? And so again, I think it really speaks to the strength of having this collegial team, because these are the exact same things that we talk about in our tumor board to recommend the safest and best thing for the patient.
Wonderful. Thank you. It certainly like gives you a sense of relief knowing that there's this whole team that's watching over you, really. We have another question about outside of a CT scan, about some new technology of a swab. Is new technology in screening that would be used?
So I think, for lung cancer, the definitive diagnosis is made with a biopsy, right? You really cannot make that diagnosis without having tissue. Certain imaging characteristics are highly suspicious, but still you need a biopsy. Now, a swab, of course, has come into play with COVID, right? The way we diagnose COVID, someone comes to the emergency department, they have fever, they have cough, their oxygen is low, they get a nasal swab that literally goes near their brain if you do it properly, and that gives you a diagnosis of COVID. Unfortunately, that is not technology that at this time helps with a diagnosis of lung cancer. Of course, technology is changing daily and many techniques, but as of now, I also saw a question about liquid biopsies. So that's something that's not quite ready for prime time yet, but I think in the near future, we may be utilizing it more. Liquid biopsy is a blood test that may be very specific for certain types of cancer. For example, PSA elevation at least makes you think of prostate cancer. Some other marker elevations make you think of colon or ovarian cancer. Lung cancer, we're not there, but we're getting close, and we do feel that within 5 years, that may be a big part of our armamentarium.
Terrific. Thank you so much for that. And if you don't mind, one more question we have here. How would you distinguish between actual lung cancer as opposed to nodules seen on a scan from other means?
That is another great question, and you guys are really showing your knowledge. Maybe you should come to our tumor board. You're asking the same questions we frequently ask. So we break down lung cancer risk into historical factors, right? And then into radiologic factors, and we try to integrate. So for example, a 20-year-old who never smoked, who comes from Cleveland, who has a lung nodule, there's an infinitesimal chance that that's lung cancer. It may be a histoplasmosis or some other benign entity, as opposed to a 64-year-old who has a 150-pack-year history of smoking. That history makes us think much more of cancer. Now, that's the historical. Then we look at the imaging characteristics. Now, again, I don't want to get too technical, but as Dr. Harrison did earlier, I'm going to take a little liberty in that if a nodule is perfectly round and not what we call spiculated, or if it's what we call calcified, so it has a lot of calcium in it, that suggests chronicity, which we would think more of a benign nodule, as opposed to a spiculated nodule that has sort of an angry appearance. That's one that we would think more cancer. So we look at many factors, but in particular, what's the patient-specific risk and what's the radiologic risk. And then we try to integrate those to come up with some type of risk formula for each specific patient.
Wow, thank you so much for that. And it's funny, you mentioned about the tumor board. One of our attendees wants to know if she can get an invite.
That's fine with me. We can reach out when we're done, maybe via email, and give you the link to our next tumor board.
Wow, that's incredible. Reach out here. I have the number here. I'll share it again. But really, thank you so much. This has been so incredible to hear from you, Dr. Harrison, Dr. Sala, Jennifer, Lou. We really appreciate your time today in answering so many questions and giving us so much very, very important information. And certainly we can, all leave with knowing that, we can reach out, we can reach out to New York Presbyterian, reach out to Brooklyn Methodist Hospital, and be able to be in wonderful hands and be able to go through that lung cancer journey with people who really know the best mode for that journey. So thank you for your time. I know you're very, very busy, and we so appreciate your taking the time to be with us. Thank you to all our attendees for joining us today. As I mentioned, this is being recorded. You will get a link to the recording. We encourage you to please share it with your community, your friends, your family. We want to get this information out there. It's so critical. And I wish you all to stay safe, stay healthy, and we'll look forward to seeing you on a future webinar. Have a great afternoon, everybody.
Thank you.
Thank you.
Thank you.
Bye-bye.
Thanks.